immunologic status at that point. So it's interesting that it's an independent risk factor. But you want to measure your blood pressure and you want to verify and control your arm. You examine the optic fundi. I know y'all already talked about, y'all did HE in HENOT module. You talked about things that happen. What kinds of things happen in the fundus if a person has blood pressure? What kind of changes can you see? Papilledema, AV nicking, I heard, copper wiring, wool cotton exudates, you know. Okay, so, but you've seen those. Calculation of BMI. Do y'all know how to calculate BMI, or do you know how to plug it into a program? Just have it on the phone, pull it up, and just type it in and get it. If you're lucky, you'll be an assistant that will calculate that when you enter the data into the electronic medical record. And if not, find the program. It's important. Auscultation of carotid, abdominal, and femoral bruise. You're looking for those renal artery stenoses. You're looking for carotid occlusions. So you're looking for complications or potential causes of high blood pressure. Palpation of thyroid gland, if you're hypothyroid. Exam of heart and lungs, exam of abdomen for enlarged kidneys, masses, and abdominal aortic pulsation. I know y'all haven't gotten into the abdominal evaluation yet, but you'll be looking for things. It's a kidney disease that could be the cause of hypertension. When you're looking for bruise from stenosis, you can evaluate in that area. Palpation of lower extremities for edema and pulse, and the neurologic assessment. Have they had TIAs? Have they had a stroke? What kind of neurologic findings do you have? Laboratory assessment. These are tests that can be done. Everything is not going to be done. I'll try to give you some kind of feel for what you usually will see done in practice. These are the J&C 8 recommendations on what to look at. You do a lot of these baseline assessments for a couple purposes: to identify what extent there might be organ damage or other involvements, but you also want it, and it's a prognostic feature, or it can help in prognosis. The other thing is you need a lot of these things baseline before treatment to figure out where are they, because sometimes the treatments that you use can have impacts on this, or your findings will lead you away from certain medications before you start. So you need this as baseline so you can follow through. But EKG, you want to see if they've got cardiac disease, and I know EKG is probably a dirty word in here right now with all the EKG workbook, but you need that. And you also need a prior to selecting some drug therapies, because there are some drug therapies that have significant effects on the electric system inside the heart. Urinalysis, to assess for secondary causes of hypertension. You're looking for protein, creatinine, albumin protein ratios, red blood cells, etc., which will help in evaluating that. And you'll get more of this when you get into your renal module.
And you only have isolated, like a 3+ count red blood cells on a urinalysis to indicate an organ problem with hypertension?
Say that again.
Can you have an acute, like, I had a patient actually last weekend with extreme high blood pressure and 3+ RBCs, and everything else on the urinalysis was absolutely normal. Absolutely. That could have been just from
It could have been just from that. But you know, you'd have to rule the other stuff out that could go with that. It could be like maybe they've got a nephritis or something. It's hard to say. But it could do that. Depends on how, what if they're burst, you know, what if they had like these huge elevations, you know, this big driving pressure, you can see things, and then maybe it's episodic, and then you won't see it again later. Blood glucose to assess for diabetes, which would be a comorbid condition that would increase risk, or for secondary causes of hypertension, and to establish a baseline before drug therapy. When you have, if you have high cortisol, you don't have to take, you don't have to be making notes on this, but if you had high cortisol or exogenous prednisone use, you might see elevated glucose because of that. It's one more test among several that will help you kind of lean that direction. Hematocrit, you check that in a patient evaluation. Elevated hematocrits can be associated with high blood pressure all by itself. It's a problem of too much erythropoietin, okay, high hemoglobin, hematocrit, and high blood pressure. Serum potassium should be looked at also to assess for secondary causes. In hyperaldosteronism, what happens to serum sodium? In
Retention.
hyperaldosteronism, aldosterone does what at the distal tubule? Sodium and water goes in, what goes out? It's a sodium-potassium exchange. So your sodium and water's coming in with aldosterone, but you exchange a potassium. So what will your serum potassium look like? Lower. So when you run just a Chem 60, if you saw somebody who had, a low sodium, you kind of have to wonder, a low potassium, where is that coming from? Is that a cortisol thing? Is it a medication thing? It could be a diuretic thing. Who knows? But you want this baseline because there are issues with serum potassium, and you all appreciate now that potassium, too high and too low, can cause arrhythmias, can be a factor. So some drugs that might increase potassium, and we'll look at these again, the ACE inhibitors and the angiotensin II receptor blockers can increase potassium, so you need a baseline. What if you already have a high baseline potassium to start with and you're getting ready to look at an ACE inhibitor? Just for fun, there are some diabetic patients who operate at the high levels to begin with because they already have renal disease from their diabetes. Their potassium might be 5 or 5.1. And then you can come in here with an ACE inhibitor, you might go to 5.5, 5.6 and have issues. I have seen that happen. May decrease potassium. Diuretics are notable for that. Thiazides and loops are two that will do that. Okay. Creatinine or estimated glomerular filtration rate, you're assessing for target organ damage. Is the kidney affected and to what extent, if at all? And to establish a baseline for drug therapy that might affect renal function or that may require dosing modifications depending on their current level of renal function. ACEs and ARBs may lead to increases in serum creatinine in some patients. Now these drugs are interesting. ACE inhibitors and ARBs are used for renal protection in a number of conditions, but they can also cause renal dysfunction in selected groups of patients. So you can't just in your brain think ACE inhibitor helps me with renal problems. That's true for a lot of patients. Is it true for all patients? No. You can select an ACE or an ARB in a patient who already have renal dysfunction and you can create the shutdown. So you have to look at their status baseline before you make that selection. I just want you to be cautious about that because they're so commonly used. You need to know some things about the patients. Calcium. You're evaluating for hyperparathyroidism, one of the things that could cause high blood pressure, so that's a screen for that, and it establishes the baseline before some drug therapies. It's interesting that the diuretics don't affect calcium the same way. Mostly, the two big ones that you use are furosemide. Furosemide actually gets rid of serum calcium, so calcium levels can go down. And hydrochlorothiazide, a commonly used diuretic, actually increases serum calcium. So that's just a little element to pay attention to when you get into details. I know that we don't really teach cancer therapies here, but you can probably hear about paraneoplastic syndromes. There are some cancers that produce calcium elevations for a couple of different reasons. And the treatment for those people a lot of times is load them with saline solution and give them a big dose of furosemide to flush all the calcium out of their body. So sometimes it's used therapeutically, but it can do that. Lipid profile is used after 9 to 12 hour fast just to determine baseline cholesterol status and also to establish a baseline because some medications can affect it in negative ways. Mostly at the doses we use now, it's not a big issue. It used to be a bigger issue several years ago, but there are still individual patients where you might actually see things get blown up. And diuretics and high doses can cause problems in some people. Not commonly, though. Urinary albumin excretion or albumin-creatinine ratio is another that's an optional test, specifically if you have diabetes or there's some presence of renal disease to give you some baseline before you start the therapies. Some other tests that can be done, and this you will probably see these in specialist offices, but some practitioners are beginning to work with this. And I'll be kind of curious from your perspective. Have you seen people use C-reactive protein a lot? My primary care provider in internal medicine follows me with the C-reactive protein. It's one of their annual screens, They also do homocysteine. It's just one of their screens to figure out, do you have any inflammatory process going on that could affect your arterial structure in such a way that you're at risk. So these are some other measures. If you had a person with active, already with established heart disease, or many risk for that, you might see these drawn. So C-reactive protein, just a general marker for inflammation, could indicate coronary artery inflammation. Homocysteine, high levels of that are linked to strokes and heart attacks, possibly part of plaque formation. And then elevated heart rate, I told you, was the Framingham study independent risk factor. High baseline heart rates that don't vary a lot, okay, that kind of stay up there. More extensive laboratory testing can be done in people depending on other issues, but they're not generally indicated for people unless their age, history, physical exam, blood pressure severity, or initial labs suggest other causes. So I gave you like the initial screening things, then based on those, you may go further and deeper to figure out what's going on. But you know, you're going to be checking blood pressure, you're going to be doing a physical exam, you're going to be checking all the locations we talked about. You'll probably get a urinalysis, you'll probably get a Chem 12 or something. A CMP gives you most of what you need to get going, unless something else is showing up. Another reason to go more extensively is if blood pressure responds poorly to drug therapy. Maybe there's a secondary cause you have not identified and you just haven't, you can't get good control. Or the blood pressure begins to increase for uncertain reasons after being well controlled. Sometimes you'll see that. They just do very well for 2 years and all of a sudden it's just out of control. Well, what has changed in their body? What else is going on? Has some new condition popped up on top of just, you know, essential hypertension? Or the onset of hypertension is very sudden. Okay, here's screenings for identifiable hypertension. These are screenings for those secondary causes we talked about. We'll just look at these fairly quickly. Chronic kidney disease, you can estimate a glomerular filtration rate. Drug-induced, just history and drug screening with individuals to be sure you know what they're taking. Coarctation of the aorta is usually angiography. You have to get a picture inside to see what's going on anatomically. Okay, in coarctation, very much like Professor Reggio said, you might see decreased pressure in lower extremities or delayed or absent femoral arterial pulses. Things are just, you're just not getting good flow down. If you have Cushing syndrome, we talked about this, or other states of excessive glucocorticoids, obviously you do the history, but you can do a dexamethasone suppression test to see. I'm not going to expect you to get all into the weeds on this because they will show up again a little bit later, but a dexamethasone suppression test lets you understand how functional your axis is, you know, for producing cortisol. People with Cushing syndrome, have y'all talked about it anywhere yet? Not really. Have y'all ever heard of truncal obesity? People who are obese in the middle of their bodies, kind of big and round like the apple.
They thought my dog had it, so he had some of this.
My Sheltie has Cushing syndrome right now, and and she's being treated for that. But usually the picture is truncal obesity with kind of like wasting of the extremities, and they have the buffalo hump, and they've got the stria that you can see, moon face. Yeah, Professor Roach gave you some more throw in there. Moon face, round, skinny out here, stria. Yeah. When you've seen one, you'll know it. They're kind of notable. Okay. Pheochromocytoma, I already told you a little bit about this. They do 24-hour urine collections, and they're looking for metanephrine and normetanephrine. Those are just the metabolic byproducts of catecholamines. Okay, you can suspect it in people with labile hypertension. They're very hypertensive, they're normal, very high, normal. Headache, palpitations, pallor, and perspiration. That's kind of the story that you get from them. Primary aldosteronism and other mineralocorticoid excess states, 24-hour aldosterone level or specific measurements of other mineralocorticoids. You may see unprovoked hypokalemia. That's why when you go, if a person is not taking medicines, and you know they're not, and you come and scream they have a high blood pressure, they got a low potassium, you have to think something like that. It's not normally going to happen without it. And then renal vascular hypertension, this is a little bit hard to pick up. Is yours renal vascular, is yours just essential?
No, my sister scanned my renal there.
So you've had this ruled out? Okay.
I'm sure that's what it was.
But no, it's just
It was too much.
bad genetic pool. we're all in there. So Doppler flow studies or magnetic resonance angiography. You may see elevated creatinines or abnormal urinalysis in people with renal parenchymal disease. I'm not going to expect you to know all this until you get to the renal part, but look, there is some stuff here I do want you to know. Renal artery stenosis. If you have renal artery stenosis with subsequent renal hypertension, these are the people who've got stenotic lesions in the renal arteries going to their kidney beans. Here's what it should be suspected when people have this. Onset of hypertension before age 30 in the absence of a family history, or onset of significant hypertension after age 55. So if you just boom and there's no reason, you got to look for a stenotic lesion, or you're older, you've gotten up to 55, never had it, and all of a sudden you have it. There could be something going on. And those folks usually high cholesterol, they got other factors that have been happening. An abdominal bruit, especially with the diastolic component, accelerated hypertension, or hypertension that had been easy to control but is now resistant. I think this is missed a lot of times in primary care because, let's say, they had essential hypertension and they've had it for 10 or 15 years and it's been just controlled on medications. But maybe it's kind of been off and on control because they're not compliant all the time. Well, that driving pressure inside those renal arteries can lead to stenosis and plaque formation just like in the rest of your body. Then all of a sudden your blood pressure is not controlled at all. So now maybe you have a superimposed another event that makes the blood pressure hard to control, but it's not going to be picked up necessarily in practice because for so many years it's been primary, essential hypertension. Now something else has happened. So when stuff doesn't work anymore, you have to start thinking of something new in the picture that we did not know before. Okay. Here's more stuff. Here's some other things about renal artery stenosis. Recurrent flash pulmonary edema, just boom. Renal failure of uncertain etiology, just out of nowhere, especially in the absence of proteinuria or an abnormal urinary sediment. Because the problem is that you're not getting any flow. It's not the kidneys blown out because there's something going on inside the kidneys, because there's no flow and it's kind of shutting down on the other side. Okay. Acute renal failure precipitated by therapy with an ACE inhibitor or angiotensin receptor blocker under conditions of an occult, unknown bilateral renal artery stenosis or moderate to severe volume depletion. This one can happen more often than you know, particularly in people with diabetes. If they've had diabetes for a while, you can almost be certain that the renal artery vasculature and the microcirculation in the glomerulus is not that has been affected. And then you place that person on an ACE inhibitor, and what they do is they shut down that circulation in a way that you all of a sudden have creatinine going through the roof and precipitate acute renal failure. That's why you want to have baseline creatinine, potassium before you start one, and then see afterwards what's happened, because if it's going to happen, it's going to happen fairly quickly. Okay. Sleep apnea, sleep studies. Has anybody here had a sleep apnea study? I have. I have sleep apnea. Truth revelations. I have sleep apnea, but I'm controlled. Thyroid and parathyroid disease. You may see hypercalcemia, but you can use a TSH or a serum parathyroid hormone. So that's kind of it. So now you've heard all about what it is, risks, workups, evaluations. Now let's talk about how you actually treat high blood pressure. And some of these things you had. Did y'all talk about hypertension diets in nutrition? Did y'all talk about the DASH? Somebody talked about DASH. I know DASH came up. I heard it in the presentations. Did anybody do DASH, or did y'all else talk about it? Okay.
There were a couple of plans we did that were like similar to DASH, which is why I got brought up, but
okay. But not just by SHREP. Well, DASH is the one they still like it. So let's look at the treatments. lifestyle modifications obviously is foundational for everybody, not just the ones on drugs. Everybody needs to be on this. And actually, it's a good lifestyle to adopt for yourself, even at your age now. All patients with hypertension and those that wish to follow a healthy lifestyle. Lifestyle modification should always be continued concurrent with drug therapy. What happens is when you move to drug therapy, you kind of give up on working with lifestyle changes. I understand that, I get that. You've tried, they don't really want to do very much, so just move into drugs and don't keep talking about healthy lifestyle. I think you just have to take it on as a constant issue that needs to be paid attention to. And sometimes, based on the stages of change for a person, you may need, if you bring it up often enough, they finally are ready to make a change. Sometimes people are not ready for a change. They're in that pre-contemplation phase, they're not even thinking about it. Then you might bring it up as a matter of health and they are ready to finally adopt it. Lifestyle modifications may effectively treat hypertension in people with small elevations. Lifestyle alone can reduce blood pressure. I have seen it, and it is not a fake notion, it's real. So here's the lifestyle modifications. First is to lose weight if they're overweight or obese, and your goal is to get the BMI between 18.5 and less than 25. That's where you're going, okay? I have given you on these slides, there is a little bitty green, there's a little green thing up under here. What I've given you, you don't have to know this, but I want you to see it. It shows you what the systolic and or diastolic blood pressure effect of that lifestyle changes if implemented for a person. Because what used to always bug me as a student, they would say, well, if you do so-and-so, it'll help you through blood pressure. And I always want to know, well, how much are we talking about? Is it a big deal or nothing? You know, not a big deal. Well, it can be pretty big in some people, okay? So I just want you to have faith that it actually does something, because after a while of doing lifestyle talk, and not seeing a change, you begin to think they don't work. Well, they do work. Okay, so you see the reduction there. Adopt DASH, the dietary approaches to stop hypertension eating plan, and I don't want to go into the details of that, but it's fruit, vegetables, low-fat dairy products, reduced concentrations of saturated total fat, which I've already talked about, the good fats, the bad fats, and food rich in potassium and calcium, which may etiologically help control blood pressure. Okay. Reduced dietary sodium, we've all heard that for forever, should be reduced to no more than 2.4 grams of sodium, which is the same as 6 grams of sodium chloride daily. I wanted to look at what are we doing right now in Oklahoma. I couldn't really find the number specific for Oklahoma, but in the nation, we have a lot of people who are out of compliance. The average intake is now greater than 3.4 grams of sodium daily. So it's like almost 1.5 times above what it should be. And the new dietary guidelines have recommended no more than 2.3. Thought that was interesting. The DASH is less than, that is 2.4, no more than 2.4. Now they say 2.3. Maybe if they make it lower, we'll get closer to right. Increased physical activity. So patients should engage in regular aerobic physical activity such as walking at least 30 minutes per day on most days of the week, and that can be very helpful also. Can also help with that resting heart rate. Moderation of alcohol consumption, and there is a sex difference in this one. Okay, so for men, to limit alcohol to no more than 2 drinks containing a total of 1 ounce, it's 30 mils of alcohol, and I've given you some of the sources and how much. That's the amount that you found in 24 ounces of beer, 10 ounces of wine, or 3 ounces of 80 proof whiskey, or 1.5 ounces of 160 proof whiskey. It's better. Okay, women, okay. Okay, are y'all calculating your weekend? Okay, don't let this take the starch out of your fun. Okay, if you're doing like the craft beer tour in Midtown, you can burn that 24 ounces before you get out the first joint. Okay, just realize see that systolic blood pressure going up. Okay, women and lighter weight persons limit to no more than 1 drink per day. Okay, so sorry. So sorry. Okay, unless your bill calls me, I don't know what he offers. his for me. Okay, sorry. And it's realizing I don't know what Bill Cosby offers his dates. Oh, man.
Oh, my goodness.
See, there you're paying attention now. If I just slide one up underneath all the time, you may get one. Okay. All right. Any question about the lifestyle? So it's, it's moving, losing weight, eating properly. All of those things are important for controlling blood pressure. And really anything, honestly, a healthy lifestyle is a cure for a number of things, or certainly prevent them. Let's look at what the recommendations are. They come out, they're interesting the way they write them, and I'll try to explain why they do it this way, but they're just straight out. In the general population, aged 60 or over, so you've got to look at age of person because the goal and the initiation point varies depending on certain conditions, and one of them is age. So if you're 60 years old, they say initiate pharmacologic treatment to lower blood pressure when a person's systolic blood pressure is greater than or equal to 150, or the diastolic pressure is greater than or equal to 90, and you treat to less than 150 or less than 90. So if you're 60 or older, 150 over 90, that's your lines, and that's where you start going after drug treatment. So that's recommendation one. Now there's a corollary to the recommendation, okay? In the general population aged over 60 or above, if pharmacologic treatment of high blood pressure results in lower achieved systolic blood pressure, that's like less than 140 millimeters of mercury, and the treatment is well tolerated and without adverse effects in that person or in terms of their health or quality of life, you don't need to change anything. What they're saying is that if a person is below the 150 and the 90, how low is okay? As okay as they tolerate is what they're saying. And the reason they wrote this is because this guideline, this JNC8, actually floated the blood pressure cut point up. And for years it had been 140 over 90. And they floated it up for that older age group. So they're saying, okay, if they've already been treated down low, should we back off the gas so that they're not as low as they were before? And the answer is not necessarily. If people are tolerating it, it's okay. I think actually it's a true statement. The lower a person can tolerate blood pressure, that's probably a healthy since it's a continuous, risk factor and variable. And that's what the argument's all about. The issue is how much more morbidity and mortality do you prevent and at what cost. The studies are idealized perfect conditions. And in the real world practice, it's not idealized perfect conditions. And what studies find is not what happens in the general population. It's not necessarily predictable. I'm going to give you one little statistic, and you do not have to write this down, please don't. But the advocates for that lower blood pressure, the American Heart Association, American College of Cardiology, there is a study out there that they pretty much based it on. It's called the SPRINT trial. And the SPRINT trial person, the person who ran that study, is the person who drafted the new guidelines. So there's an industry influence, and that's one reason the family physicians pushed back, is that they felt like, why is the leader of new guidelines giving us their bottom line in a study? And the result, the study was stopped early because there was a 25% reduction in relative risk in those people. So, ooh, man, 25% reduction, we need to take care of all these people. Well, look at it a little more closely. They looked at people who were treated to the low levels. They had a 6% risk of cardiovascular morbidity or mortality, and the people at the higher level had an 8% risk of cardiovascular morbidity and mortality. So hence the 25% reduction in relative risk. Stated another way, the people who were treated to the lower goal, 94% of those people, there was no change in what happened to them. Okay, they're okay. And then in the other group, where there was 8% reduction, the other 92%, there was no change. So when you look at the vast majority of people in both groups did very well. Do you want to treat a ton more people at a bigger cost? And in a non-idealized situation, do you actually see that benefit? And that's the question. And I don't know the answer, and neither do they. So that's why there will be pushback. Okay? Because treating older people to lower levels is risky. What if treating older people to the lower levels lowered blood pressure so that you had fewer heart attacks, and you could prove it was just a fewer heart attacks that was statistically significant, but the rate of fractures from falls went up by 5 or 10%, which has its own mortality? The studies would say, well, they didn't die from cardiovascular mortality, but what is their overall mortality in general? Have you saved them from one only to put them at risk for something else? And the answer to that question is unknown. So that's why the primary care providers have to push back on it, just for fun. Okay. All right. Recommendation number 2. In the general population less than 60, that would be most of us, except I'm now in that 60 or above group. So sad. In the general population less than 60, initiate pharmacologic treatment to lower blood pressure when the diastolic blood pressure is greater than or equal to 90, and the goal is to treat it to less than 90. Okay, that's one. Now look at this. Recommendation number 3 is if you're less than 60 years of age, you can initiate pharmacologic treatment to lower blood pressure when the systolic blood pressure is greater than or equal to 140, and you treat to less than 140. So the cut point for people less than 60 is 140 over 90. The cut point for people who are 60 or above is 150 over 90. In the younger group, if they're over 140, you can look at drug therapy plus lifestyle. If they're over 90, you can look at drug therapy plus lifestyle, and your minimum goal is to get them below 140 over 90. That's your first approach. Doesn't mean you can't go lower than that, but that's your first approach. Recommendation number 4. Now you get into comorbidities to make a decision. In the population that's greater than or equal to 18 years of age with chronic kidney disease, you initiate pharmacologic treatment to lower blood pressure when it's greater than or equal to 140 over 90. So it's basically the same. If you have chronic kidney disease and you're greater than 140 over 90, that's where you want to start using drug therapy. Recommendation number 5, people with diabetes. Okay, so if people who are over 18 who have diabetes, again, it's greater than or equal to 140 over greater than or equal to 90. You want to get them to at least less than 140 over 90. So now we have age, the 60 or older, less than 60, the people with chronic kidney disease, the people with diabetes. The people that are 60 and below, kidney disease and diabetes, they're all 140 over 90. Recommendation number 6. Now we're getting into racial groups, ethnicities. In the general non-black population, including those with diabetes. So if you're non-black and including those who have diabetes, the initial treatment should include one of 4 groups of drugs: a thiazide, a calcium channel blocker, an ACE inhibitor, or an ARB. Okay, so there's some guidelines on where you start. Recommendation number 7. In the general black population, including those with diabetes, initial antihypertensive treatment should start with a thiazide or calcium channel blocker. So, if you're non-black, you have 4 categories that you would use to start with. If you are black, whether you have diabetes or not, you start with a thiazide or a calcium channel blocker. Okay? Interesting. It's going to get a little more interesting. Okay, recommendation number 8. In the population 18 or older with chronic kidney disease, initial or add-on antihypertensive therapy should include an ACE inhibitor and ARB to improve renal outcomes. This applies to all chronic kidney disease patients with hypertension regardless of race or diabetes status. So kidney disease people, you're trying to use an ACE or an ARB to preserve renal function if they're at a point that they can tolerate the use of that medicine, and with monitoring. Okay. Number 9. This is a long one. Okay. The main objective of hypertension treatment is to attain and maintain the goal blood pressure. That to me is a duh. If goal blood pressure is not reached within a month of treatment, you You can increase the dose of the initial drug or add a second drug from one of the classes in recommendation 6, which is thiazide, calcium channel blocker, ACE, or ARB. The clinician should continue to assess blood pressure and adjust the treatment regimen until the goal of blood pressure is reached. Okay, it continues. If the goal cannot be reached with 2 drugs, add and titrate a third drug from the list provided. Do not use an ACE and an ARB together in the same patient. Do not use an ACE and an ARB together in the same patient, which would mean that you would know an ACE and ARB by name. Okay, I will give you a few of those. If the goal blood pressure cannot be reached using only the drugs in recommendation 6 because of the contraindication or the need to use more than 3 drugs, then there are other classes you can choose out of. But you have to be familiar with thiazide area, ACE, ARB, and calcium channel blocker. That's the pool that you're usually going to be working out of, honestly. And then it continues. Referral to a hypertension specialist may be indicated for patients in whom goal blood pressure cannot be attained using the above strategy, or for the management of complicated patients whom additional clinical consultation is needed. Okay? And there will be some that happen that come along that you just cannot get controlled. Okay, this table is simply a breakdown of what I have just said. And just look at it, it's kind of straight across the board. There's the age, greater than 60, age less than 60, all ages, diabetes present, no chronic kidney disease, all ages, chronic kidney disease present with or without diabetes. So look at the people over 60. The goal is less than 150 over less than 90. People less than 60, the goal is less than 140 over 90. Diabetes, all ages, less than 140 over 90. Blood pressure goal for chronic kidney disease, less than 140 over 90. Pretty much, if you don't know anything, you know 140 over 90, you got 3 out of 4. Just to figure it out. It's the old people that is the difference coming out of blocks. Then you move down here, look at the age. You look at whether a person is non-black or black. Non-black, thiazides, ACE inhibitors or ARBs or calcium channel blockers alone or in combo. Black, thiazide or calcium channel blocker alone or in combo. And then chronic kidney disease is all races, ACE or ARB alone or in combo with other drugs. Okay, so it's not that hard to figure out, just kind of looking at it right here. Strategy A, these are strategies for dose titration. I have my own personal views about this, others have theirs, but I just want you to be aware of what they are. Strategy A is start a single drug and titrate to a maximum dose and then add a second drug. Okay, the advantage of that is that they have one drug. You don't have more pharmacology floating around the tank. You have the adverse effects of the one, but not of multiple things being added in. So that's not a bad strategy, keeps things simple. Strategy B, start one drug and then add a second drug before achieving the maximum dose of the initial drug. So that's kind of like I'll start you on one, if that didn't work, I'll start you on the second one, and we'll keep 2 together. The advantage of that is minimizing adverse effects at higher doses. The disadvantage is now you have 2 medicines, unless you put them in a combo tablet. And that could be more cost. And if you're a Medicaid patient, that's a punch. And then many of y'all recognize, if y'all appreciate Medicaid, have any of y'all worked within it?
I work in a pharmacy, yeah.
You know, if you're in a pharmacy, you know, but if you're a provider, a primary care provider, and you've got a patient with multiples, you know that they have a certain limit on prescriptions that they can get done over a period of time. And when you start looking at treating hypertension, there's usually diabetes, lipid disorders, asthma, anxiety, there's all these prescriptions. Then you get into complexities. When you start making a complex drug regimen, you have to learn how to work the system to get medicines for a person. But suffice to say, keeping things simple and cleaner is helpful for some people and some plans. Strategy C is to begin with 2 drugs at the same time, either as 2 separate tablets or as a combo. And look at the green box is important. Some of the members recommend starting greater than or equal to 2 drugs when the systolic blood pressure is over 160 and or the diastolic is over 100. So if it's the systolic blood pressure is 20 above the goal and or diastolic is greater than 10. What they're saying is that when you have higher blood pressures, you very often need 2 drugs to get them down anyway. And rather than go into visit, follow up within a month, follow up within a month, follow up within a month, is you kind of appreciate that a larger percentage of those people with higher pressures would need more than one drug and maybe come out of the blocks with combo to get it down. Okay? It saves visits and follow-up and kind of gets you to the end point quicker. So that's what I'm saying. There's nothing wrong with any of these. They all have pros and cons to them. Most patients should return for follow-up and adjustment medications at approximately monthly intervals until the blood pressure is reached. Monthly is kind of gives you a chance to see what they're going to do if they tolerate it. There are a couple of medications where you actually do need to have about 3 to 4 weeks in the tank before you evaluate them. One of those is thiazide diuretics. They do not show you their full effects until about 3 to 4 weeks out. And that's basically where this recommendation comes from. I'm not going to test you on this, but when you just talk to you, just listen. That diuretic, you really do need to go about 3 to 4 weeks out to see it, because you'll see a reduction, and if you bring it back in a week and try to dose again, you don't appreciate the full effect of the first one, so you end up stacking doses sometimes, you get too low. Now, you may have to move quicker when the person has really high blood pressure, but ordinarily, a month is fine. Beta blockers is another drug that takes about a month to show the full blood pressure effects, but they're not in the first rank of drugs that we're going to look at using to take care of people. But that 3 to 4 weeks for the thiazides are okay. ACE inhibitors, calcium channel blockers, if they'll take that medicine, you usually see what you're going to see within about a week or so, a week to 2. So moving on with a little more speed and focus is not really that wrong. And honestly, I think there's something good about following up the ACE a little bit sooner than later anyway, so you can move faster. But the recommendation is monthly intervals. It kind of works for everything. It's true for all of them. That's why we're saying it. You can do more frequent visits if you think if their elevations are significant or they have complications that, like they've got chest pain that's kind of off and on is an issue. Another reason for more frequent visits in people, and this is just a management issue, if you've got somebody who is low literacy that you don't think really is going to be able to be compliant because they haven't shown it before, it doesn't do any good to give a likely non-compliant person a medicine for blood pressure, which you are saying needs to be controlled, and saying return to clinic in 6 months. If they weren't going to be, because you didn't think they were going to be compliant, you're not going to know again for 6 more months whether you've done any good or not. So I think with non-compliant people, it helps to get them back quicker to prove to them and yourself that they are able to follow through with instruction, and then you get into the long-term management. But you have to look at your clinic, your load, your volume, can you get folks in? There's all these elements we're playing into it. Follow-up and monitoring, serum potassium and creatinine should be monitored at least 1 to 2 times annually or more frequently when using medicines that may affect renal function. And we've talked about diuretics, ACEs, and ARBs. Aldosterone antagonists would do it too. Or for people with comorbid conditions. So a Chem 6 will usually give you what you're looking for. You get potassium and creatinine, and that's a good baseline and follow-up. After the person is at goal and stable, you can move out to 3 to 6 month intervals to be sure that all stays like it needs to. Okay, I'm going to stop right there and ask you if you have any questions about what we've done so far. Because we now covered the disease, the evaluation, complications, and the beginning of treatment all the way up to drugs, which is kind of another whole ball of wax. Any questions about what we've done so far? Does it make sense? It's a flow, okay? Go have fun. I'll see y'all at 1, okay?